Good afternoon, everyone, and welcome. We are so glad you're here with us today. Whether you're joining from your office, your home, or catching this during a quick lunch break, we truly appreciate you taking the time out of your busy day to be part of this conversation. We have nearly 50 people now. We are expecting a little more than that, but that really speaks volumes about the shared commitment across our hospitals to using data not just as numbers, but as powerful tools for change. And so we truly want to engage you today into improving a little bit the accuracy of your data and working through the report that you're going to start getting this month. But before we dive in, I want to take a moment to thank our teams and data abstractors. Over 90% of our hospitals have already submitted patient data for January and February. And because of that, we have been able to identify a few areas where things weren't quite aligning. So that insight helped us add a few checkpoints in REDCap to improve data accuracy moving forward. And even though that may sound like a small technical fix, it truly makes a difference in making sure we're working from data that truly reflects the care being delivered. So we're hoping to see increased data accuracy moving forward. So thank you. Thank you for your time, your attention to detail, and your continued dedication to the initiative. Today's conversation is all about building on that foundation, making sure that the data that we're collecting tells a story that we can trust and we can use to fuel real lasting quality improvement. So let's get started. Next slide, please. Just a few housekeeping items. Please make sure that you are muted so we don't have a lot of background noise. If you have a question, please enter it in the chat or raise your hand, and that is located under the reactions button. And this webinar is being recorded. It will be available in our website along with the slides after the session. Next slide. So today's agenda, we're going to go over some common data errors that we have found in the baseline data. We're going to go through a couple of example scenarios and that REDCap data quality checks that we have added to the system. We're going to go through a few commonly asked questions that we are seeing a couple of people struggling. And we're also going to look at a few of the graphs that you're getting in your prompt data report. We're going to have two sections for questions. So if you want to keep them for those sections, you're welcome to, but truly, if you want to just drop your question in the chat, we will address it during that time as well. Next slide, please. So I think you all have met us, but this is the data team from the FPQC. My name is Estefania Rubio. I am the Associate Director of Healthcare Data and Informatics. More than happy to respond to any question you may have. My email is in the slide. But in my team, I also have Shelby Davenport and Alexa Mutchler, both spectacular, very talented data analysts that are also part of the data team and always available to answer your questions. They are the ones that are running your reports, sending your reports, doing the very heavy lifting on the FPQC side. Thank you to all of you. Next slide. So we're going to go into those common data errors that we have found in the baseline and those additional checkpoints that we have added. And for that, I have Alexa.
Okay, so we have built in a couple of error messages in REDCap to try and hopefully keep you guys on track with some common errors that we're seeing. So the first one is we're seeing a lot of people giving medication within the first 60 minutes of an initial severe hypertension reading, but then there's no confirmatory reading noted. So if a patient is given medication within the first 60 minutes of the first severe hypertension reading, then you must give us a time and a location for the confirmatory reading. So remember that a confirmatory reading is a second severe blood pressure reading 15 to 60 minutes after the initial reading. So in REDCap, this is what it will look like. You have your medical management table. You've got your first reading at 15:32 in the EMS. You've got your medication given within 60 minutes at 16:15, but there's no confirmatory reading here. So you'll see an error message pop up that says antihypertensive medication was given within 60 minutes of the first severe hypertension reading, but no confirmatory reading was noted. So I'm going to show you what that will look like in REDCap. So down here on the medical management, you'll put in 15:32 or whatever the time is. you're going to give your medication within 60 minutes, but there'll be no confirmatory reading here. So when you scroll down to the bottom, you'll see an error. You can ignore this bottom one for now. There's more errors on my entry than just this one. But you'll see a message that says, you said you gave antihypertensive medication within 60 minutes, but there's no confirmatory reading. So that's the first error. The second one is if the first reading is in an OB unit, any OB unit, then the first and the third lines of the medical management table must match time and location. So for example, you've got your first reading in triage at 1532, but you put that the first blood pressure reading in an OB unit was at 1545. Well, that doesn't make sense because your first ever reading was at 1532 and it was in an OB unit. So by that logic, the first lines and the third lines need to match. So you'll see an error pop up that says the first severe hypertension was in an OB unit, but the time and the location of the first two lines, or the first and the third line, excuse me, in the table do not match. So in order to get rid of that error, you'll have to make them match. So we'll go back up to here. Let me clear this data out. So if I've got my first reading at 1545 and it's in the triage unit, but for this reading, I put that the reading was at 1749, you're going to get an error that says, effectively says that first line and the third line don't match. Okay. Next error is there have been some instances that we've seen that a patient has received an antihypertensive medication, but then the time or the location was left blank. So if you give a patient an antihypertensive medication, or not you, but the patient was given an antihypertensive medication, then we have to know the time and location. That's critically important because our main aim is timely treatment. And if we don't know what time the medication was given, then we can't calculate timely treatment. And as a note that we'll talk about here in a second, if the patient only receives magnesium, then you're going to leave this line blank because we're only asking for time and location of an antihypertensive medication, not magnesium. So if you mark that, for example, labetalol was given, but you've got a blank line for the time and location for the first antihypertensive medication given, you're going to get this error. It's going to say you indicated that the patient has received antihypertensive medication, but there's no time or location. So that looks like labetalol being checked here. Make this equal so that hopefully that error goes away. If you choose labetalol, but this line stays empty, you're going to get an error that says you indicated the patient was given medication, but you haven't told us what time or location. And then on the flip side of that, if the medication given was only magnesium, then you're going to leave that line blank. We specifically are asking for the antihypertensive medication. So for example, you choose magnesium sulfate bolus, but you're put a time in here. This is going to give you an error. It's going to say, you indicated to us that no antihypertensive medications were given, but you told us a time and a location anyway. So on here, that would look like a simple switch to magnesium only, or that would work for just maintenance or any combination of these, or if you choose none, this will also show up. Well, it's supposed to. This is a good check because, oh, it's because there's no time in here. So your medication, you popped up saying you indicated they were not given medication, but there's a time in there. And then second to last thing here, we have had some, because we're not collecting dates, it's really important for us, for you to tell us if the medication administration crosses over into a new day. So for example, you've got a patient whose first reading in the OB unit occurs at 11:34 at night, and medication isn't given until 1:30 the next morning. Well, right now we're kind of just guessing based on as much logic as we can muster that it was given the next day. But now we've put in a check mark for you to tell us, yes, this medication crossed over midnight and was given the next day. And you'll see this error message pops up. It says the first antihypertensive medication was given prior to the first reading. Are you sure this is correct? And then once you click that med was given the next day, that will go away. So let me show you how that works. And that will work in the OB unit or the first reading. So let me reset all of these. So if you've got a first reading, and then a medication given at midnight, you can choose med was given the next day up here. And the same error will occur if for some reason this first line isn't filled out. It will occur with the OB unit as well. And you'll just tell us medication was given the next day. And you'll see that we've added a time to treatment from our OB unit in minutes, so you can kind of keep track of that as you're entering data. And you'll see that if you don't choose this med was given next day, REDCap calculates it kind of funny because it doesn't know that these are different days. All it's doing is reading 2 timestamps. So when you choose med was given next day, it knows to calculate it appropriately, and it tells you, okay, it was given within 60 minutes. So that is what this slide is showing you, with different numbers, of course. So you can see here that this medication was given within 21 minutes, and we have this calculated down here for you. But like I just showed you, it's critically important that if it crosses over, if the medication administration crosses over into a new day, it crosses midnight, you must check the box. Otherwise, the time to treatment will not calculate properly. And this is pretty close to the numbers I just gave you. So if you just leave it like this, it's going to tell you that there's almost 1,400 minutes that it took to timely treatment. But if you check the box, it will calculate it correctly and tell you that it was 49 minutes to treatment. And then one last thing, we have added a accuracy acknowledgement statement at the bottom of the survey that you must check before you can submit it. Right above the acknowledgement of accuracy, that's where we have all the errors popping up so that you can see right at a glance whether there's any errors left. So you won't want to check this until all of these errors have disappeared. I believe that's all I have. So Stephanie, I know we're going to take questions after this commonly asked questions section. So I'll kind of monitor the chat while you're doing this, and then any questions you have about the REDCap survey, we'll take in a minute.
Sure, thank you, Alexa. Yeah, we have quite a few questions, great questions, and we'll get to them in a second. So we are going to go through 3 commonly asked questions that are part of your data collection. Next slide, please. So the first one is regarding the BP cuff. The question is, did the patient have a BP cuff to take home prior to discharge? And so to say yes, the patient was given a BP cuff to take home, any of the following must be true. The patient was given a BP cuff by your team. The patient is set up for remote monitoring, or the patient has a BP cuff that was brought in for calibration. So that has been most of the questions we've gotten. We have a patient that has chronic hypertension. They have been, checking their BP. They have a BP cuff at home. Can we just check yes for that? And just to standardize the measure, we ask that that is a very nice and a great opportunity to calibrate the cuff. So as long as you ask the patient to ring their cuff and you check it, verify that it's working well, then that's all that's needed for those patients that may have a BP cuff at home. But that's their requirement. Next slide. So we do have a poll question for you, and this is in regard to one of the questions in the data form. It reads, was the patient verbally briefed on their persistent severe hypertension before discharge? And so the question for you is, when abstracting a case, what do you look for in the EHR to confirm a patient debriefing took place? And please check all that apply, and you have the options there. Thank you everyone for answering the poll question. So thank you, Shelby, for sharing the results. You see that most of you are doing patient education on severe hypertension, that's 64%. 27% have their physician and nurse present. 51% are reviewing the clinical course with the patient and including treatment and procedures. 36% on providing that written summary of events. 31% are also looking at the clinical team debrief form. 40% are doing postpartum warning signs, and a few marked other or unknown. And this is very valuable information. So the thing that you are all and most of the teams are looking at is patient education on severe hypertension, which is a very important element of the patient debrief. But we wanted to just go through a couple of the items that should be included. So shall we please go next? Thank you so much. So patient briefs, we're talking about, was the patient verbally debriefed by the provider, and that can be the physician or APRN, or with the nurse present to reinforce information on severe hypertension before discharge. And so a verbal debrief is a structured conversation involving the provider, nurse, patient, and their support person. The provider needs to clearly review the clinical course and include the treatment and procedures specific to the patient. And along with that, they have to provide a written summary of the event to the patient and the support person for them to review after the event and the admission, right? Because at the time they may not be in the headspace to absorb all the information that you have shared with them. So those two things are critical. The patient education on severe hypertension should be provided both verbally and written. And you have to also include a plan to follow up in 3 to 5 days, and the appointment should have been made for the patient and then reinforced. Next slide, please. So this came from Margie. Margie has been looking through, where those things could be documented, and she noted the provider progress notes, the provider discharge summary, or maybe the patient's written and verbal discharge instructions. But just looking at patient education wouldn't suffice. It wouldn't be enough. You really have to see if the nurse and the provider had that conversation with the patient. Next slide, please. So Margie again shared a few considerations for discussing those severe hypertension events with patients and the support persons. We need to use simple language and confirm with the patient that they understand, remembering to pause for questions when explaining the event. The clinicians should be listening to the family and patients and respond to their questions and needs. During the conversation, really the clinician should assess the patient and family's emotional response, address trauma or anxiety associated with the event, and provide resources as needed. The clinicians should offer times for questions for clarity. The provider documents the plan as part of the plan of care or the discharge instructions, and the nurse should document the discussion and reinforce the information. The nurse also needs to notify again the provider if the patient is not clear on the events and the plan of care, and utilize the skilled communicators, interpreters if needed, and then clearly delineate the follow-up plan with written discharge instructions. So as you can see, it's a very structured process, way more than just sharing education on severe hypertension. It really needs to be a conversation between the provider, the nurse, the family, the patient about the specific details of the event that the patient just went through. And all of this is because we've seen a higher link of postpartum stress disorder on patients that have this type of severe events, and having these conversations truly help them, digest all the things that happen and understand what happened during the hospital stay better. Our patient advisors truly have been very vocal about the importance of having these conversations, specifically coming from the physician and the nurse together, and not just having some education on severe hypertension. So please, as you go through the abstraction of the data, make your team aware that the debrief is much more than just the education. If that's the case, I know that some hospitals are doing fantastic on the debrief already, but some may still have some additional processes that need to be added to the conversation, so it can be fully a patient debrief that has been discussed with both physician, provider, and the family. All right, next slide. So we have some definition reminders as well. For the medication protocol, we have asked if the patient was not given the medication timely, right? So if the patient was given the medication later, maybe after they had the second or the third severe event, and you are reporting on the first event, we still need to know the time, location, and the medication that the patient received, Because if you think about our aim, we're looking at timely treatment. So we want to be able to calculate how much time have passed between the first severe event and when the patient got the medication. So even if the medication wasn't given in response to the first event, please make sure that you give us the time when the antihypertensive was given. And so whenever if you leave that blank, you saw that Alexa share that with you. If you leave the time when the medication was given blank, you're going to get a checkpoint message to make sure that you include that if an antihypertensive medication was given. If that medication is given later on, right, and it was not given in response to the first severe event, it was given later on, and you mark it and you give us the time, the place where you can tell us that the medication protocol was not met is in the follow-up question, right? You know that you have the check mark for the antihypertensive, and then we ask you, was the protocol met? So if the medication was given untimely later on, then you can check, no, the protocol was not met. Next slide, please. So we have an example. The patient's first severe hypertension reading was at 8:32 a.m. with a confirmatory reading 15 minutes later. And then the first medication was given at 1:56 p.m. Next slide. So when you complete that information, you have your first BP, your confirmatory, and then this was done at the same place in the OB unit. And then you give us the time of the first antihypertensive. Please remember that we're only asking the time of the first antihypertensive medication, not for magnesium, just the first antihypertensive medication. So that is labetalol, hydralazine, nifedipine, or other antihypertensive medication that is listed in your protocol. But we're going to be checking back and forth, right? So if you check that you gave an antihypertensive and we don't have a time, where you are going to get an error message, and over time we're going to send you a couple of messages to please complete that, because our aim is timely treatment. So we want to know how much time lapsed between identifying the severe event and providing the medication. So that is very vital information for this initiative. Next slide. Yes, and that's just to confirm that you would say, yeah, it was the time, and then you just tell us it didn't follow protocol. Okay, so we have a lot of questions. We're going to assign about 10 minutes for questions. So let's see how far we can go, and then we have an additional 10 minutes at the end. And if we are not able to get to all your questions, we will follow up via email, but let's try. So shall we? Or Alexa, go ahead.
I was gonna say, there's been a couple of similar themed ones. To be clear, for prompt, we are counting triage as an OB triage. If they're triaging in an ED, then you would want to mark ED so that we know it's not an OB unit. Because if you mark triage for the first reading and then the reading is different in an OB unit, it's going to tell you that error that they need to match. So if they're triaging in an ED unit at your hospital, then you'll want to mark ED. So that was the first one that covers a couple of questions in the chat.
Yeah. And, one of the options that we can give you is, if you have been using that consistently for multiple patients and you want us to change that for multiple patients, we can do it on our end. Email us. We're happy to help you. If it's like one thing that has consistently been entered for patients, instead of you having to go through all those cases, we can help you on that end. Okay, so Shelby or Alexa, can you please go through the questions that haven't been answered, and maybe we can address them together?
Yeah, so Andrea asks, if they have a non-confirmed blood pressure, then later have a severe hypertension episode, do you count the first non-confirmed BP as the first elevated blood pressure if both are in the OB unit?
Okay, so if you had a severe reading that didn't get another documented BP within 15 minutes, that is the burden of proof. So you would report that one, right? But if you had one severe reading and then you had another reading that was non-severe and not another non-severe reading for an hour, then you don't need to report that one, because it was an isolated reading that had a follow-up non-severe BP documented, right? And then you can go to the next severe event, which would be one severe reading follow up with another consecutive or non-consecutive severe reading within 15 to 60 minutes. So those two case scenarios, basically. So if you don't have a documented BP after the first severe reading, that is burden of proof. For documentation purposes, you put it as a severe event and you report that one. But if you had an isolated severe reading and then you had a non-severe reading within 15 minutes, then you don't need to report that one. You need to report the following when you had another severe event that was confirmed as severe.
So there's another question that says, to clarify, in order for us to select yes to the patient being educated on their severe hypertension episode, we need to have a structured provider education added.
For the debrief, yes. Because we have several education measures. So not all of them require, the structure conversation, but the question that is specifically asked if the patient was debriefed, then yes, you need to have the provider and the nurse present in that conversation.
This
Okay.
this was a question. This was a question for the group, but I am encouraging you to respond because I'm also interested in y'all's answers. But someone asked, "Does anyone currently provide a written summary to patients?" I assume you're asking with the patient discharge debrief. So respond to Jennifer if you do, or come off mute and tell us about that. I'd be interested to know what your written summary looks like, or if you're using a template from another organization.
Yeah, and Mindy asked, how would someone calibrate a blood pressure cuff?
So Margie is in the line, I think. Maybe this is a Margie question. I think I saw Margie. Hi, Margie. Sorry to put you in the spot.
Great to see everyone. No problem at all. What we're asking is that you compare it ideally with your blood pressure cuff to make sure it's reading accurately. And ideally, it's a manual. I know a lot of you out there don't do manual blood pressures. Eventually, you might, but just make sure their cuff is matching or within millimeters of mercury that's acceptable with your blood pressure cuff. So if it's off by 30 millimeters of mercury for the systolic, you've got a problem. So you want to make sure that it's validated when they come in. Does that make sense? Oh, Mindy, you said it'd be more accurate to say you validated the
No,
cuff.
that was me, Margie. I was typing a response to that when you popped on to answer it verbally. So I think I basically said the same thing you did. That they're not really calibrating a cuff, they're validating a reading.
Exactly.
Perfect. We can change the wording, and that's more accurate. You're absolutely correct. So validating the BB cuff.
And then Mindy also asked, what qualifies as a written summary of the event to the patient and support person?
So we do have a sample for a written summary. It came from the Alliance for Maternal Innovation. We're more than happy to share, but basically you have several sections where you would put the procedures, the medications that the patient received, and if there were any complications. And then the last section is on the follow-up care. We're more than happy to share that with you all. The sample written from, just written it down so I don't forget. After the webinar, we can send you that via email.
Grace, I see your hand is up. Do you want to hop in before I keep going with the chat? If you're talking.
No, Grace.
Well,
we can't hear you if you're speaking. I see that you're unmuted, but we can't hear you.
Grace, you might want to type in the chat. There might be something wrong with your audio. Okay, while she's doing that, Brittany Morgan asked, just to verify, to count the patient had a debrief completed, the MD/nurse/PT have to be present at the same time, or does the debrief was completed by the MD and the RN at separate times count?
Ideally, we would want both present at the same time, but I know that's not possible for every scenario. Margie, please take that one on.
Yeah. practice as the nurse is present because you want to be able to reinforce what was stated. So that's why we provide our nurse together. So if you're around with your physician, so they're documenting in their progress note or their discharge summary, and you're documenting in their nurse's notes. So yeah, that's the best practice.
Jessica said, we've had a few direct admissions for severe blood pressures in the office, but never had any severe pressures once in the hospital. What do we do? Admitted and started on magnesium, but no severe events the entire hospital stay.
So we are not collecting information for patients that were identified in the patient's office, on the provider's office. So if they were not sent to the OB-ED and then processed from there, or through the ED, those wouldn't meet criteria, unfortunately. So you would just not include them in the sample for the data submission. Now, everything else that we're doing for these patients, right, everything that you're implementing as part of the persistent severe hypertension bundle should be given or should be provided to the patient. Just for the data abstraction, you wouldn't include those patients in the sample because to standardize the measure and so we can compare across the hospitals, we are not collecting information on patients that came directly from the physician's office and didn't have another event, right? If they came and they already had no severe hypertension once they came to the unit, then you won't be able to give us the time for the first severe reading or the antihypertensive, so it wouldn't really help the data set. So just for data abstraction purposes, we would ask you to exclude those patients from the sample. But again, everything on the bundle should be applied for the patient as appropriate.
Samantha and Sally both have said that they have submitted a patient who had their hypertensive episode 4 hours after delivery, but we only have option for how many days after delivery on the form. Not sure how they would report that.
I'm sorry, Alexa, could you please read it again?
Yes, Samantha said, I submitted a patient who had their hypertension episode 4 hours after delivery. There was only an option for days. I assume she's talking about there's only an option for number of days after delivery on the form. And Sally said, yes, we did as well.
Got you. So you would just say 0, day 0.
Yep. Allison asked, if a patient has a severe blood pressure, we must cycle the cuff for an hour, regardless if the following 15-minute blood pressure has come down to non-severe.
You would follow your protocol there, but yes, you should usually check on your patients for a period of time before they're moved. But you follow your protocol in that situation.
So I am just gonna chime in. Can you hear me?
Yes.
So we usually, like in the labor period, most of the time the cuff is cycling, but I guess based on your definition of what persistent severe hypertension is, if we have one at 11 o'clock and then we have one at 11:45, but the two between that were normal, then we would treat. So I guess that's where the discrepancy is that's not our current practice to cycle it for an hour. We would just get one and take them off the monitor if it's in the postpartum period. But then how do we know if they had persistent severe hypertension? Because we probably wouldn't check it again for 4 hours.
Got you. Well, those are the new guidelines, and it's part of the bundle that we are updating, right?
Okay.
Before it used to be consecutive. Now we are looking at non-consecutive readings, and we do need that hour after the first event.
Okay.
So that's something that, it's completely reasonable right now in the baseline. This is something that we are just implementing, but that is something that we hope that hospitals move.
Okay. Yeah. And I do think that's what we're focusing on is like that's going to be our big change.
Yeah.
Okay. Thank you.
Thank you. Margie, do you have other observations there?
I would just say reference that beautiful article that's in the toolbox from SMFM on that. The examples they give you really helps a lot to explain to your team why you're making this change. And it may take a little time, but getting eventually to that, monitoring them, following them closely if they have a severe for that out.
Yeah. Thank you, Margie. All right. Do we have any other questions?
will say there's been a couple people that have said that it didn't allow them to put 0 days postpartum. I just changed that on the
Okay.
back end, so you should be able to now.
Perfect.
I don't think there were any questions in the chat that I missed, but if I did, please unmute and ask us.
There is
Perfect.
one more, and I want to ask it because we've had this asked a couple times via email. But when we were asking, were the meds provided prior to discharge, is this referring to new antihypertensive meds or the old ones that they're on for chronic hypertension?
Well, the old ones, the patient should have a prescription already from their provider. So we're looking at if they are getting new antihypertensive medications. But honestly, like if the patient still has like a standing prescription, if it was changed, like if the medication was adjusted in any way, then that would also apply. So if there are changes to the medication, the antihypertensive medication that the patient is taking, then yes, please answer that, whether or not the patient got it.
Awesome. Thank you so much. That's our last question for now to stay on time. But
All
you
right.
can continue to write your questions into the chat and we'll get to them as we can, / we'll stay on longer too to make sure that all your questions have been answered. All right, so now we're going to get into the reading your monthly report section. So far, you have gotten one monthly report. It has been the light version, so just a couple of pages. But as we get more data, you guys are also going to get more pages added to your report. So I want to go over what the report looks like and where we're getting this information from. All right, so for those of you that have been in other initiatives before, this page looks familiar to you. So this is page 2 of your monthly report. It goes over the attendance and coaching calls, the total number, and the number that your hospital has been in. It also goes over data collection. So your abstracted patient level data that's due monthly, how many of those submissions you have or how many you're behind. And then lastly, we have hospital level data, which is due quarterly. And of course, we have how many your hospital has submitted and how many are due. So your eyes might be drawn to the 2 stars on the side. Does anybody know what these stars are called in our normal star report? Those of you guys that have been in PAC or other initiatives. So they are your attendance and your data collection stars. So probably in the next month's report, after we have 3 months of data, we'll start showing you guys your stars that you've earned. And so 2 of those stars come from this page. So it's a good page to check in and see, am I up to date with my data submission? Am I getting credit for all these coaching calls that I've been on? This is a great landing page just to make sure that all your information's correct and to make sure that you're getting those 2 stars. So next you have your hospital level measures page, is page 3 in the report. This comes from your hospital level data. This is what we like to call the stoplight grid. So it has all the different policies and procedures and guidelines that we ask you about if your hospital has, fully implemented or maybe just now planning or starting to implement. So the level of implementation is represented by our little checks and X's in the circles here. And then we have all of your policies, procedures, and guidelines in the same order that you see them on the hospital level data submission form represented here. They're just a little bit shorter. And on the right, we have the various different topics of educational criteria that we ask you about in the hospital level data submission. So this usually is one of our hospital capacity stars, looking to see if you've fully implemented the majority of these policies and procedures. Next, we have our monthly key measures. So this is patient level data. This is your abstracted patient level data where you collect that sample we've been asking all these questions about. That's going to be shown here. As we go over time, you're going to collect more and more months of data, and this is where we'll start to look at our trends. So after 3 to 6, probably about 6 months of data, you can start looking to see if your hospital has a positive or negative or staggered trend. So this will be a great space to come back to once we've collected more data. Now you might be wondering why, because I've gotten a question about this. On the right bottom corner here, you have 2 lines, and none of the other ones have 2 lines. Why is that? Well, this measure is asking, how many of the patients, how many were scheduled for follow-ups 3 to 7 days post-discharge. Well, we have 2 lines because to get this measure, in the patient level data, we ask you, was a follow-up scheduled within 3 days, or was the scheduled follow-up within 3 to 7 days? So we have both of those here just so you can see the difference between the 2 groups. And this page is new. This was not on your last report, so this will be on your upcoming report that you'll get either end of day tomorrow, end of day Monday. And this is our timely treatment variable. So this comes from your patient level data, from a lot of the images that you've been seeing today. That's where this information comes from with our timing and our location. So for timely treatment, this is specifically focusing on the OB unit. So this measure is the percent of patients that have received timely treatment for severe hypertension in an OB unit. So to get this measure, it's looking at the first severe hypertensive reading in an OB unit, and then the time that has elapsed between that reading and the first medication given to the patient. For it to be timely treatment, we are looking for under 60 minutes or under for this. So the percentage of patients that were treated within an hour for severe hypertension is what this graph is showing. This is a colorful box and whiskers plot. I don't know if you guys remember that from school or other math classes that you've taken, but this is just another way of looking at those quartiles that a box and whisker plot shows us, but just represented in colors. So our legend's on the right, so you can see how your hospital compares to all the other hospitals in the initiative. The black line will be your hospital. And this is averaging for all of our hospitals right now. But when you get your report, you'll see the black line will be your hospital. And then the back colors blocking here are our lowest 25%, lowest 50%, highest 50%, and then the highest 25%. And then this pink line here is the median. So this will be how you'll compare yourself to and how your timely treatment is progressing among other hospitals. At the bottom here, we've also included readings in the EMS and then timely treatment for patients in the ED EMS with your average time. So just different ways of looking at this measure. You've got that represented here in this chart. And as time comes along, you'll get some more of these charts with different measures, but this one will be in next month's report. Next, we have adverse outcomes. This, of course, is being funneled by our abstracted patient level data that you guys submit to us. So we have our balancing measures at the top. And this is out of percent of patients with hypotension. So out of those with hypotension, how many of them have interventions or corresponding deterioration in fetal heart rate and C-section due to hypotension? So something to view your balancing measures, that will be the top of your adverse outcomes page. And then after that, you have diagnosis at discharge and then adverse maternal and neonatal outcomes here for you guys to see. So some more poll questions for you guys. Let me launch the first one. I just want to know, has your team began to share your prompt data? You've gotten your first report. I'm sure you're jazzed to show everybody on your team how you guys are doing. Who has already began to show their data? 56% of you have already began to show your data. That's amazing. And 44% of you have not. And that's okay. I want to go over some examples to show you guys that haven't shared your data how you can share this data. Okay, and for everybody that has already begun to share your prompt data, how have you guys done this? What strategies have you utilized? So out of everyone that's already shared your data, you guys, the strategies that you've utilized, the top one, number one, is OBGYN meetings. You guys have been sharing it. Wonderful. Next we have email, which is a common method that I've seen. If you guys ever want to share with us your data sharing emails or reports or posters, we'd love to see them. Next, other, and then we have break room posters and grand rounds. So we have 14 hospital or 14 people with other. Could you guys either come off mute or write in the chat what are other ways that you guys have shared your data?
We do it in staff meetings and on our lens board.
Awesome. Thank you, Kathleen.
We do it as well with a Friday update, which is kind of like an internal electronic magazine that we share within our department.
Awesome. Thank you, Shamika. All right, so some great strategy you guys have shared. I'll have to add that to my list for next time. So you guys have gotten some examples from your counterparts here about different ways that they've shared their data. Other ways I've heard is grand rounds, different meetings that you guys have, email, or your break room wall or another common space wall. So now we've got 10 minutes left for some more questions. I'll check the chat.
Hello, Shelby. This is Nell. How are you?
Hi, Nell. I'm doing good. How are you doing?
Good. I have a question for the certificate for the STAR criteria. Is it the same as the PAC initiative?
So we have not come out with our STAR criteria yet for prompts. Usually we do that after 3 months of data, but we do have similar stars that have been used in PAC that will be used in prompt, and that would be your data collection star. So for those of y'all don't know, that star is obtained whenever you are up to date with all of your data. All of your data, meaning your hospital level, which is quarterly, and your abstracted patient level, which is due monthly. And then attendance. We usually look for 80% or higher in attendance of your coach mentor meetings for the data collection star, as well as a data sharing strategy. So you guys have utilized one of the strategies I've told you for sharing your data, and you have attended 80% of the meetings. That's your attendance star. But Estefania, did you want to add anything to that?
No, that was great. So the other three stars are related to the aims. So one will be around timely treatment, and the other two are around structural measures and probably education, but we haven't set it down yet in paper because we want to get the full baseline data, which remember is the 3 first months of the initiative. Once we have that, we set goals. Because right now we know that our aim is to improve by 20% timely treatment and education. But we also know that some hospitals may start very, very high, and a 20% increase is very difficult to get. And so for them, we would set another goal line, usually around 70-80%. But we need the baseline to be able to have a realistic goal for everyone to attain. So that's why usually we share the STAR criteria a little later. So I think we should be sharing those STAR criteria with the coaching groups by the end of May, beginning of June. So coming your way. But as Shelby told you, 2 stars that don't change are the attendance and presentations in your coaching calls. We really appreciate all of you being engaged, and then submitting your data promptly and making sure that you share your data with other teams, and well, not teams, but everybody in your unit, so everybody's aware of the big changes you're making.
Thank you.
And probably the hospital capacity star too, right? Or we still need. whether that's a possibility too, Nell, but you saw that in PAC with your stoplight grid there, so maybe that will be a star too. But more to come in your coach mentor meeting, probably either next month or the month after that. We'll let y'all know that way.
Thank you.
Absolutely. Are there any other questions that we haven't addressed, we have missed, or maybe you want to come out of mute and share your question now?
I have a
You.
follow-up question about the blood pressure reading.
Mhm.
If we have the confirmatory blood pressure reading before 15 minutes, it still falls in the initial population, right?
Yes.
Okay, just want to make sure. Thank you.
Yeah. The recommendation is between 15 to 60 minutes, but I know that for some patients, that reading may be done before 15 minutes, and you just report the one that is closest to 15 minutes.
Great, thank you.
Thank you. Great question. Any other questions?
While we're waiting on questions, I have a statement to make. Make sure that you got a data report from either myself, it was me last month. If you did not, you can search for our name, but I also want to make sure that you don't have any firewall issues coming from us. So if you can't find an email from us with a data report in it, then maybe it would be a good idea to reach out to your IT department, or if you know a way to add like approved senders to your email, you can add our emails. I just want to make sure that everybody on our contact list is getting the report that needs to be getting it. So we have, your QI team that you submitted to us, we are sending the data reports to them. So usually your lead, your data lead, hospital admin lead, a nurse champion, and a physician champion, I believe. So it's usually about a team of 5 that we send it to, or sometimes more if you include more people, but
Yeah, that should be
yes.
coming your way. Stephanie, I see your question in the chat. Did anyone share their structured brief documentation for the severe hypertensive episodes that involves the patient? We don't have one specific for hypertensive events. However, if anybody out there has, the documented debrief already in the system and would love to share, we would love to have it. And we're always looking for tools to add to the toolbox. Because really, like, others can use it, and if you have already gone through the trouble to produce it and you're willing to share, it really helps teams around the state. We do have some examples for OB hemorrhage, so I know that some of that will be, usable for hypertension, and we do have one debrief form that is more standard for patient debriefs, and that's the one that we are going to be sharing with you after the webinar. But yeah, so far we haven't gotten one specific from hospitals in the state on the debrief. Shannon, I see your raised hand. Go ahead.
Question, I may be confused, but we get the emails from data from you, but there's a website we can go and log in to review historic data, correct?
Yes, so the perinatal quality indicator report has information on severe hypertension, but only on severe hypertension. Is that the one you're referring to?
Yes, I was looking for any kind of historic, because I'm trying to collect our data. I don't have my predecessors' access or emails from FPQC, like for the PAC and for prompt. So if I lose my email, is there a website I go to that I can log in and then look at my hospital specific information?
No, we would have to grant you access. So please email us with a request. We're more than happy to work with you because we have to get you a USFNet ID. It's a whole process, and we're more than happy to do it. But it's not publicly available data because remember, we have that privacy statute with everybody with the data user agreement. We don't share that publicly, but we can work with you on getting you access to PAC if you need it from your hospital. More than happy to do that. Just please send us an email. We'll follow up too. And we're almost at 1. So there's one more thing I wanted to ask you before we close. Shelby, can you please go to the timely treatment graph for a second. And this is a big request for our teams because this is our aim. And so you're going to start to get this graph starting this month. It's very, very important that you start to see how you are doing. You can use the quartiles to set a benchmark if you want. For the state, usually we use the median. We are going to add a goal line after the 4 months once we get those goals set with the advisory committee. But one important thing to do in this graph is to start to document when you do a PDSA. So every time you run a change and you do a test, it's very nice when you can document the time when you do it so you can see if it had an impact on the measure. So that would be my only last request for teams. As you look at your report, look at the timely treatment closely. Remember, the graph is for all the patients that were seen on the OB unit. And we have separated the patients that were seen in the ED and treated in the ED versus those that were seen in the OB and treated in the OB, just so it's easier and there is not too much confusion about, when was it and the things that you can control or not. But for our graph, we're looking at those patients in the OB department. So pretty please look at those closely. Those are our aim. That's the one that we want to impact the most. And please annotate as you do your PDSAs. And we are at the top of the hour. So if you have to jump out to another meeting, thank you so very much. Email us if you have questions. We are going to stay on. We don't have another meeting, so we can stay on to take additional questions if you have them. But if you have to jump out, we thank you so very much for your time. Shannon, please go ahead. I see your hand raised first.
I think she had already asked her question.
Yeah, maybe it was before. Melissa.
Hi there. Okay, so my question is where the medications followed protocol, dosage and timing. So if the nurses are giving the medication within the hour, but they're not necessarily following our protocol to the T, like say the blood pressure is supposed to be repeated in 10 minutes and they do it in 15, does that make that answer a no? Or is it still a yes because they got medication timely?
Well, if the protocol was followed for the medication, then you would mark yes, because the BP readings are a little separate, but it all depends on your protocol or in your individual protocol. The question is specifically asking you if the medication protocol was followed. So I wouldn't mix them up.
So Melissa, I think the answer would be no, because we're asking if you're following your hospital's protocol for giving medication. So even if it met that 15-minute to 60-minute mark that we're asking for, if you didn't follow your hospital's protocol, then the answer is no. Does that answer your question?
Yeah, because the protocol is more than just that one medication. Then it's like, okay, they have to take another blood pressure, and then if that one's high, they have to give this. So if it doesn't hit on the marks, like the 10-minute, 20-minute mark, then I was answering no. I just wanted to make sure that was right. So
no, you're absolutely correct. Thank you for the clarification.
And then while I have you guys, I have one more question. So was patient discharged on meds? And it says, if yes, were meds provided? Does that mean physically provided, like they delivered to the hospital and given to the patient?
Yes. That is physically provided to the patient.
I took that. Okay. All right. So yeah, is that what we're striving for? Because we've never done that here.
Yes, that's again a best practice. And we're tracking that one. But that is not, the biggest aim. I'll tell you that. We would love to see that one improve. There's a lot of hospitals that are doing meds to beds programs and have it, those options. But yeah, it's physically having the patient leave the hospital with the medication in hand.
Okay, gotcha. And is there any information on how other facilities are making that happen? I know about 10 years ago or so, we used to have Walgreens and CVS, they used to have delivery services. That's kind of stopped around in my location. And then we have patients they use all different types of pharmacies. So is there like one certain way that people are streamlining that, or?
That would be a great question for your coaching call, unless anybody else has a good insight. We have been hearing in coaching calls a couple of examples. There's a hospital that is working with Publix that is just across the street, and they're working, to make sure that the insurance is going to take that. But it's very region or hospital specific. I don't know if it's going to apply to everybody, but it's great to, hear those ideas and maybe test them out in your facility. Margie, do you have a better recommendation there? Sorry.
Yeah, I would just say bring it up on your next coaching call. And within your hospital grouping, your system might have, which system are you with?
HCA.
Okay, so yeah, with the HCA call, bring that up because I am sure, I know how you guys do things corporate and things like that. As maybe right now, maybe it got dropped because of COVID or something or maybe they don't have an agreement anymore. But I would say bring that up on a coaching call and see if someone in your system's looking at them. Because that
Okay.
is the best practice that they have it in hand before they go home.
Okay, all right, thank you.
Great work.
Mindy had asked, I see Shelby kind of already answered this, but she asked for hospital level measures. Do you have guidelines for what meets each requirements? And then Shelby linked the toolkit. That's really the best place to see what those guidelines should look like. If you're only looking at the red cap version, it's kind of got the survey online that you answer. It's kind of got condensed wording. So if you're looking for more expanded wording, you can look at the PDF or the paper version of the hospital level data collection form that will have more words. We were just trying to condense it a little on the survey. Go ahead, Melissa. I saw you had one more question.
Yeah, sorry. So I've been
No, you're
hitting a couple of instances where patients are hypertensive and catch it in the moment, and I'll go and speak to the labor nurses, and they're saying that it's related to pain, and they're not treating, and they're saying, well, we're about to give an epidural. If we give medication, blood pressure medication at this time, her pressures could bottom out and drop. And then, they'll say, okay, well, since we got her epidural going, she hasn't had any other episodes. So, but I mean, it's significant blood pressures. They're pretty high, and they're just calling it pain. So is anyone else seeing that? And is there a spot where the physician feels like that's really what's going on, that we can document why, it wasn't, would that just be like clinical judgment in that, the reasons why it wasn't given box?
Thank you, Melissa. Great question. So first, we always ask that you verify that the blood pressure was valid. That's our very first step always, because if the patient was truly in a lot of distress and a lot of pain or was in a contraction, then maybe you want to have another blood pressure taken when the patient is in between contractions, right? And so that one is something that some teams are struggling with. But if that's not the case for you, then yeah, that's something that needs to be talked to with your providers and specifying the protocols, because treatment shouldn't be delayed. Margie, I know you have.
I would echo that. I also say loop in your anesthesia division into all of this, because I know, like, my son's in CRNA school and he's like, this is all news to him. So be sure you have someone that leads your anesthesia team that's aware of these values. Yeah, you're not alone. A lot of times with the pain, they think, oh, it's just pain. But if you look at the literature, it talks about if you've got a severe range, you need to treat the severe range. So, and it might take some time before you get there, but at least you're looking at it, Melissa. Keep going. And you, if you want to set up like a mentoring moment with the physician that's your coach mentor, we can do that. So, and they can speak to your physician. So,
okay, that'd be great. Thank
To
you.
answer your question about, oh, sorry, go ahead, Stephanie.
I think we were going to say the same thing. Go ahead, Alexa.
Oh, well, and correct me if I'm wrong, because I don't have any clinical background. I'm just thinking about it from a data perspective. You asked if it is from pain and then they're not given medication, do you put provider clinical judgment? If it truly is a one-time reading from a contraction, or they're pushing, or it's a severe pain situation, and it's a one-time reading and it is truly that's why, then that would not be a valid reading and you wouldn't abstract that patient to begin with.
Yeah, no, there was 2 readings. But
okay, then
to pain, and they were waiting on anesthesia. Once anesthesia came and got her comfortable, there was no more severe readings. So they were justifying that they were right in their judgment. So
yeah, then in that case it would be clinical judgment.
Okay, got it.
Gigi is a MFM and he's your physician mentor, so we can talk about that on your next coaching call.
Okay, sounds good.
All right. I think we have addressed all the questions. Maybe I see Sherry. Okay. Thank you, Alexa.
Yeah,
and there's going to be some times where patients are going to the client services and, that's the right. And again, on those we're tracking mostly because we want to see an improvement over time of other places that may not have this meds to beds program incorporate those programs into their systems. And so we're hoping to see an improvement over time. But again, that's not our biggest aim. All right. Sarah, we'll take your last question because
Sorry, just to piggyback off of her statement about the elevated blood pressures related to pain. We've kind of come in contact with this happening postpartum during just after delivery with like intense shaking as well. So I'm assuming that's just going to fall under the category of clinical judgment, not proceeding with any type of treatment just due to the immediate circumstances of recent delivery.
Right.
Perfect. Okay, cool. Thank you.
Thank you.